I'd like to thank Dr. Johan for inviting me to this conference to share some of my thoughts on CTA evaluation of coronary stents. What are the challenges we see on a CT scan? CT scan, as you know, depends upon the attenuation values of the blood, the vessel wall, the vessel lumen, and the metal or other structures which are form the part of the stents. So, whenever a CT scan is done, it comes inherently with these complications of blooming artifacts because of the attenuation of the beam at the metal part of the stent, partial volume effect, motion artifact because of heart rate variation, geometric effects due to cardiac anatomy at acute bends like L6 and RCA, and intravascular contrast enhancement. So, again, the challenges are small size of the stents, which is very difficult to, small size of the stents, multiple stents at one side, stents with more metal, calcium overlaying the stent, artifacts of sternal wires, clips pacemakers, and hypodense restenosis material in proximity to high attenuation stent. So, after having listened to all this, you will get surprised that why are we doing a CT for stent evaluation at all? Because there are more complications than what information is given. But having said that, the AI has now come up in a very big way, and it's going to help us in the near future in trying to resolve these problems of the metal artifact, the heart rate variation, the blooming artifact, so on and so forth. So now, the latest trend is to do a CT angiogram and a CT perfusion to look at the myocardial perfusion so that you have a dual modality. You got something, two modalities there. One is doing a CT perfusion and other stent lumen assessment. Both of them give a very high degree accuracy in the assessment of in-stent restenosis there or not. So some of the statistics say that for any stent more than 3 millimeters of the size, 3 millimeter size, your accuracy is above 90%, almost 95% specificity, more than 3 millimeters. But less than 3 millimeters, it falls to 84.5%. Having said that, I would like to request all of you that if you think that stent is a small stent, stent in OM, stent in diagonal, stent in PDA, stent in PLV, you know the stent size is 2 millimeters, I prefer not, I ask you not to send it for CT angio only. Only the stent size is about 2.5 millimeters. I would suggest you to send for a CT angio because of this issue of any amount of whatever might be the machine, but the accuracy falls below 80% if it is less than 2.5 millimeter stent. So that's what I've been shown about. Now, what are we trying to look at in a stent evaluation? Patent stent, you can see the stent lumen very clearly here. New intimal hyperplasia is we call new intimal hyperplasia when it's less than 50% stenosis of stent lumen. In-stent stent restenosis, more than 50% of stent in-stent lumen stenosis and stent occlusion. This is what we are going to talk. We are not going to tell you about 120, 20 to 30, 30 or 40 mild moderate severe, nothing. We are going to say in-stent restenosis is more than 50%, intimal hyperplasia less than 50% or occlusion. That is all what your CT is going to tell you, not anything. I mean, if someone tells you 30-40% in a stent lumen, that is humbug, should not believe it. Now, what are you trying to look at in the stent is direct lumen visualization. I have to look at the lumen in two directions, in two perpendicular orthogonal directions. One is axial, one is CPR or curved planar deformation. If I don't see like this, I am not doing justice. Now, if I see a stent in LMCA, wide stent, 4-5 millimeters, I can give you very good result. Excellent. Now, if I see artifacts like this because of pacemaker wires, because of acute bends and a small stent, very thick stainless steel stent material, I cannot give you. So there, I will not do justice in this particular study. So, you don't remember what kind of stent you have put. Now the patient gets to us what kind of stent has been, how much is it, how dense is the material, stent material, how long, 2011, 2010, 2009 stent has been installed, that is very difficult to know. So ultimately the criteria is millimeter size. If you think stent is more than 3 millimeters, you can send to suspect a chest pain because of in-stent restenosis. Now, what are the advancements that are taking place are two. What we are getting is known as ultra high resolution CT scan. This ultra high resolution CT scan can show the stent lumen, stent wall very clearly. Number one. Number two, photon counting CT, which costs about 45 crores now. Nowhere in Asia it is there at this point of time. Then phase contrast CT. I mean, phase contrast CT costs around 70 crores. So, I mean, these are all experimental stage. No one can afford it. So, ultimately, the bottom line is 3 millimeters less or 3 millimeters and more. That's what is going to tell us. And some examples of the ultra high resolution CT scan versus conventional CT scan. You can see here that calcium is obscuring the lumen, whereas ultra high resolution CT scan can show the lumen very clearly. And no UHRCT as on now in India. We don't have any UHRCT as on now. Again, from literature showing this. So let us look at what we can do in our scenario, in our place. Given a CT scan, they see India, made in India. What can we do? Poor man's India. What we can do? This is what we can do. This is available. Special techniques to do reconstruction where this is before and after movement artifact can be excluded. Next, look at the stent. Look at the stent by doing a high resolution reconstruction. We can look at the stent. Then, neointimal hyperplasia. This is how you look at it. This is a stent in a cross section. You can look at the hypodensity surrounding the stent. That is neointimal hyperplasia. Then look at all types of stenosis. Type 1 stenosis. You can see type 1 stenosis here. And then look at the cross section. There is hypodensity within the stent lumen. Hypodensity within the stent lumen. That means to tell us that there is instant stenosis. Similarly, type 2, you can see type 2 instant stenosis there. We can look at occlusion. Long stent, instant occlusion. Then, this occlusion, you can also look at the CTO proximal to the stent by CT scan. And CT scan can also tell us about what is happening to the myocardium distal to the stent. We can see, we can look at that. Then you can look at this case, long stent, occlusion, negative remodeling of the vessel. Distal vessel is getting negative remodeling. So for you to plan PCI, CT scan is going to help you to look at what is the size of, what is the stent, what is the vessel beyond the stent. You can pick up very well. So cath correlation, you can see that there is instant occlusion here, stent occlusion. You can see the same thing here very clearly. More than that, you can look at the vessel distal to the stent. That is what the CT scan is good. Beauty of the CT scan is, if you are planning to PCI, CT scan is the modality of choice. Then you find that there is instant occlusion, confirmed by cath, and then post stent, you can see the vessel is opened up there. So lot of advantages there. So if you want me to comment about the stent here in PLVB, better not. But I can definitely comment about stent in proximal RCA, proximal mid RCA, because the stent, the size of the vessel is larger. Similarly, progression of atherosclerosis in non-stented vessels can be picked up, or even in the stented vessels, you can pick up the progression of atherosclerosis. You can look at this severe lesion proximal to the stent. You can see here. That is again the advantage of doing a CT scan. Now, in a non-stented vessel progression of atherosclerosis, you can see here, stent is there in OM2, whereas RCA, again there is a lesion that's coming up in RCA, which patient has presented with chest pain, post-stent. You can see in the non-stented vessels also, atherosclerosis can be picked up by doing a CT scan. So what are the take-home points are, again, most important point is, vessel size 3 millimeters and more, 3 millimeters and more, please ask for CT scan. We can give you a very good result. 2.5 to 3 millimeters, you still can ask, but 2 millimeters and less, or 2 millimeters vessel stent, we cannot give you any accurate result. So what we do is, we do a lot of techniques to overcome the problem of looking at stent, and those are inherent of CT scan, and we take care of them. Those are known as, what I call them as stent boost techniques on CT angiogram, and we do a small FOV, we have edge enhancement filters, high temporal resolution, good heart rate control. I need a very good heart rate control to pick up a good stent to show it better. More the heart rate, more the artifacts. Vasodilators, we always give NTG or a sorbit rate before doing the study to widen the vessel so that I can look at the vessel lumen much better. So avoid stents less than 2.5 millimeter diameter. No matter what you do, with the scanners what we have today, the accuracy for small caliber stents is less than 50%. Cutting edge technology is coming up in a big way. We are using it. It will come probably in India in the next 5 years. Thank you very much for attention.